Okay, great. Recording is on. So thank you very much. Again, today is January 9th, 2019. This is the NEMSIS V3 implementation call. Thank you much for joining us. Folks may notice that we are beta testing a new webinar system called Zoom rather than the Join Me process that we've used in past years. We're hoping to be able to move to this product. Please let me know if there were issues getting on, or if you're having problems connecting as we evaluate this product. We want to make sure that it's going to meet the needs of you as stakeholders and us as the TAC. So I'm going to go ahead and dig right into the agenda. As mentioned, would welcome your comments as we walk through these topics. First, wanted to let folks know that the NEMSIS 2017 Public Release Research Dataset is now available. Folks will note we usually release that in September, October timeframe. This was our first complete release of version 3 data, and we faced a couple of issues with ensuring that our mapping was as accurate as possible, combining the 334 data with the 340 data. So we took our time to make sure that was completely correct, and then we released the data in December. And I'll just quickly, if I can, just show folks just real quickly where they can access that data. We would love for the states and even vendors to utilize that data to improve your EMS services and your products, or make it known to other folks where it can be found. So just on the NEMSIS website, using EMS data, if you come down here and click on Request Research Data, this is where you'll find it. You'll notice that the 2017 data set, as mentioned here in red, has nearly 8 million EMS activations in it, submitted by 35 states and territories. It includes data from over 4,000 EMS agencies. So just great work. This was truly our transition year from version 2 to version 3. And so it's easy to note that we dropped from 30 million EMS activations in the 2016 data set to 8 million in the 2017 data set. That was expected. I can tell you, as we're closing out 2018 data, and we'll be able to release the data now much more quickly now under version 3 because of the real-time data submission. We'll close that data set with about, I'm guessing, between 22 and 23 million EMS activations. So again, people are moving to version 3 quickly. There is exponential growth in the records. And on a national level, I know there's clearly value for the version 3 standard at the local level and the state levels, but at the national level, that will make for a great, really inclusive data set that, again, comes very close to representing the nation. So just great work on everybody's part in regards to moving to version 3. I'll just point out a couple things just real quick. So here you can click on the user manual that's associated with this data set. This might be valuable to just point out to folks who want to use the data set. And I'm sorry, I'm going to just move quickly down through lots of the information here and just maybe point out a couple of quick things. You'll notice here that there are reference tables associated with all of the variables that use standards such as ICD-10. We have these reference tables that not only provide the actual code, for example, in ICD-10, but also provide the stated description. So we also have an element in there that actually provides the text description of each of the codes. So as users use this data set, they won't have to be referring back and forth to some external reference as to what each of the codes mean, because they'll be present there. So lots of new great stuff. Of course, here's all the vital signs. Now vital signs come to the national level, and so these will be great additions, particularly for people looking at issues like naloxone use and recovery from naloxone. They now can do this on a national level with these elements. So some great additions here. The computed variables that we used to have are here again, of course. So we have we've computed elapsed times and provided additional information, for example, urbanicity is now based on the 2013 USDA Urban Influence Codes. So here's where you'll find the computed elements. And then I'll just mention just real quickly for the states, as you know, we're working and we're going to be talking about a little bit the V3 OLAP cube. Folks, I think, really enjoyed the V2 cube. There was a public version and a state version. These are the elements in the V2 state version that states were able to look at their data explicitly based on these variables. These variables are not available to the public. The same will be true with the version 3 cube, which we're making great progress on and should be out early this year. So we're excited about that. I think that's all I really wanted to add in regards to discussing the availability of the 2017 data. Any questions related to that data set? Okay, great. All right. Let's move on to item number 2. We have mentioned that we have a new position here at the NEMSIS TAC. Folks who remember one of the milestones of the NEMSIS TAC for 2018 will be clearly Karin Jacobson returning home to be with family. As folks know at the state level, Monet Ainacho has been the person from the TAC who's been contacting them to try to resolve any technical issues they have or to ask if the NEMSIS TAC can help in any way. That was a task that Karin did a great job of. The other thing that Karin did, of course, is she offered us our clinical expertise as an active paramedic. We're now have a position open here at the TAC called the Data Promotion Officer. This position is required to have a clinical background, either active or having not left the field too long ago. I'll just bring up real quickly in case you have folks that might be interested. If you want this available, here's the description. I'm happy to provide you with the University of Utah HR link to be able to actually submit an application. We're going to be working on posting this on Indeed and a number of other sites this week or next. And so we just wanted to make you available that this position will be available. As you can see, there'll be our clinical support person. This person will also be responsible for much of the training that goes out to you in the states or to the public or to EMS agencies regarding the NEMSIS data. So that will be incredibly valuable. We're looking forward to having that person help with those activities. They'll also help to make sure that our reports remain clinically relevant, and then with some research activities related to their clinical expertise. So this should be a really exciting position and one that will have great influence across the nation. If you know of someone with EMS experience who may be interested in applying for the position, please feel free to contact me or Lisa, and in the near future, this will be posted in many different locations and will be available that way as well. So any questions about this position? Okay, great. All right, thank you. All right, agenda item number 3 is an update on the work we've been doing with the V3 cube. Lisa, do you want to get us an update on where we are in that process?
Sure. And I also wanted to mention, Clay, that into the group that I just sent out a link to the University of Utah's job page, and in particular to the data promotion position, and it's in our chat right now. You just click on that. Sure. So with regard to the V3 Cube beta version, testing is still in progress. We started with a pretty rough version, and we wanted to get feedback right away, which we've been receiving. We're working through the complexities and unique nature to V3 data. The next major version of beta with many fixes implemented will be updated this Friday, and then we'll start our next round of testing next week. So I should have a much better idea of timeline by the next V3 call. And that's it for V3 Cube right now.
Okay, great, Lisa. Yeah, I'll just add a couple of comments as we work through this. I'm really excited about this tool simply because of the much more granularity of data that's available with version 3, plus the fact that we've added in links using the geographic information that's available in version 3. We've linked calls blinded, but we've linked individual EMS activations to census data. So really, many public health users will be able to look at calls from, say, for example, areas with a certain level of socioeconomic status or income, or single families, or poverty level. So it should provide a lot of additional value for public health uses. So that's exciting that that's moving along. Any questions about the process or progress with the V3 Cube?
Hey Clay, I did want to ask the group if anyone is not able to see Clay's screen, what should be displayed is the agenda for this call. If you're having issues, if you could just send me a private message through the chat, that'd be great. Thank you.
All right, great. All right, let's just move on to item number 4. This is just an update on our process in regards to version 3.5.0. We really want to try to provide a mechanism for you to stay up to date as to where we are with that. I'm going to just go back to the website here. Hopefully you can see this on your screens, and just remind you that if you want to follow where we are in that process, you just have to click on the opening page, this link here. It will take you to this nice screen that allows you to look really quickly at the changes that have been proposed. And if you come down to this last red box, how you can follow along, it will actually bring you to the JIRA project. And Laurel's the one that's been working through the bulk of these revisions. You can see there's probably, I think when everything is said and done, the revisions over the last 2 years that we have worked together as a group and approved or disapproved, I think there'll probably end up being probably about 150 revisions that will be included here. Some of these, as you read through these, are just kind of small atomic changes that were just part of a decision to make a change. And so there's probably fewer decisions that we made than you'll see here in regards to actual activity. But you'll note that there's at least 80 of these, I think, that are already in the in progress column. And that basically just indicates that we've reviewed it. We have a process for completing that change. That change is made, and we're waiting until we get the bulk of items into the in progress group, and then we'll release a beta release for us to do an initial review. So hopefully I'm just reminding you of where you can go to look at the changes and review the changes, look at how the changes are being made. If you had a specific interest in any specific change, you can certainly look for them here. I'll just mention those items that we've continued to work on over the last couple of months that really we haven't provided kind of the definitive decisions for. We'll do some of those today, but others, for example, the CARES to NEMSIS Harmonization project, that has been a very active project for several months, and we're probably 90% done with that. And actually, Jeremy from the Office of EMS will give us an update on that here briefly. The promotion or demotion of elements as national will be finalizing today with you on the call. So I would anticipate that probably 95% of all revisions are already in here and they're being worked. And so please feel free to go through this spreadsheet if you want to look at any particular revision and what's happening with it. So any questions related to the process of moving towards version 3.5.0? Okay, great. Well, feel free to keep in touch with us if you have any comments. Of course, as you might have noted on that page, if you're reviewing any of these changes and you have a comment about perhaps we haven't completely captured change as you described it, if you submitted it or if you're on one of our work groups or something, clearly there's a way to leave us a comment here in regards to that proposed change, and we would be happy to review that as we go through the process of implementing the requested revisions. All right, okay, let's move on in the agenda if there's no other comments. Lisa, can you give us an update in regards to performance measures project?
Sure. So just as a reminder, we, Josh concluded external testing with our vendors, with some volunteer vendors late last year. We received some great feedback from that community and are working with our development team in getting those things implemented. We put a hold on this project just temporarily late last year so we could focus on V3 Cube. And we'll be picking this project back up later this week. And then so all should have a better idea of when this will be going to production by the next phone call also. So we're just basically spending time right now making the final updates. We will do another round of testing, and then we'll have a better idea of when we're going to go to production.
All right, fantastic. Thank you, Lisa. Any questions about the performance measures project? Josh, I see that you're on the line. Do you have any other further comments in regards to this process?
Nope.
Okay. All right. Thank you, Josh. Yeah, we really appreciate the vendors that were willing to go through the beta testing process, and that's been incredibly informative for us. So thank you. All right. Let's move on to item 6. I mentioned that we had made some great progress in regards to the CARES NEMSIS harmonization process that was requested be part of version 3.5.0 in 2017. Jeremy, I see you're on the call. Do you want to provide an update in regards to what your office has been doing in regards to that?
Yeah, sure. That's great. Thanks, Clay. Happy New Year to everyone. First, I just want to thank everyone for their kind of continued hard work on the version 3.5.0 standard. You know, it's clear to Dr. Kramer and folks here in the Office of EMS how hard you all are working, and we're just really looking forward to seeing the version 3.5.0 standard finalized and tested as we kind of move forward. So we're excited about that. Regarding the CARES NEMSIS harmonization, I thought I would take just a little time to provide some background, just kind of on the process, and also maybe just describe some of the challenges we faced. I think probably most folks are aware that CARES submitted a version 3.5.0 revision request to the NEMSIS TAC back during that 6-month or so open request period back in, I think, 2017 maybe. So to be honest, you know, the request was quite broad, so it really just kind of stated that NEMSIS and CARES should fully align. And I think in comparison, some of the other version 3.5.0 revision requests were much more detailed. So for example, like, you know, there was a revision request to have DEAD with resuscitative efforts for E-disposition 19. So that's very clear. I think it was easy for folks on the DMC and others to kind of vote on that and see its value. You know, I think kind of the broad nature of that initial CARES request that we should align created some challenges for us down the road. But anyway, so the DMC did review that revision request from CARES, and Clay, folks at the NEMSIS TAC did kind of alert the DMC that there might be, you know, potentially 12 element modifications to fully align with CARES. So on the first DMC vote, you know, you had more than 50% of those that voted did think we should move forward with the request. And then on the second vote, you had 70% of the folks that voted also thought that we should kind of work towards fully aligning with CARES. So following those votes, Clay and folks from CARES had several meetings to kind of work through the unaligned NEMSIS and CARES data elements. Then Dr. Kramer and I here at the NHTSA Office of EMS, we really kind of first became involved with that harmonization process during the NEMSIS and CARES meetings or meeting that was held at the NEMSIS spring meeting in Providence last year. So at that time, NEMSIS and CARES had kind of identified 14 data elements that needed to be harmonized. And so we started just kind of continuing to work through that list of 14 to, one, kind of see if CARES could map on their end, two, could CARES make other changes on their ends, or three, you know, what changes NEMSIS might need to make to the NEMSIS standard to kind of reach harmonization. So CARES agreed really to kind of make changes on their end, either through mapping or some other change to their standard for 7 of those 14. And so following that meeting in Providence, we set up a version 3.5.0 kind of harmonization work group that included folks from CARES, several state data managers, some CARES state registrars, of course, Clay, Dr. Kramer, and myself. And our task was really to kind of work through those 7 remaining elements for harmonization. So the group was facing some challenges, and so Dr. Kramer and I offered to facilitate the work group moving forward. And kind of after that, we held 3 calls, really just kind of with the goal of doing whatever we could to reduce the burden of data entry on EMS practitioners, but also ensuring that we were, you know, collecting valid and reliable cardiac arrest data. So after those 3 calls, we came up with a solution, and there are some additional changes that don't really have to do with the harmonization. What's best, Clay? Do you want me to kind of run through those changes?
Sure, I think that might be helpful to just introduce them here. I think folks would be interested in hearing about those. Yeah, I think that could be helpful.
Okay, I don't know, do you have the kind of PDF that I sent? If not, I can just... I
do. Yeah, let me see if I can bring that up. I'll do that here quickly. Yeah, that's a good idea. Okay, let me just make sure I grab the most recent version.
So I've kind of added some watermarks to indicate what changes we'd like to make to the ERS section. So for ERS 01, there's no changes to the structure. The one modification we're suggesting is just a change to the definition. So and CARES was in agreement that would provide what they needed on their end. So just a definitional change to the field values there. A slight modification to cardiac arrest etiology in the field values. So some of the state data managers felt like this would clarify that exsanguination was medical and non-traumatic. So not related to the harmonization, but folks felt like that was an important change to make. And then no change here to this data element. A slight modification to arrest witnessed by. So instead of witnessed by layperson, folks felt like we should change this to bystander to align with language and subsequent data elements with the Epstein criteria and also what CARES is doing. So no structural changes there, just a label modification. We did decide that to deprecate this data element, which is ERS 05. So that's one that kind of a bigger change, but it will be deprecated. And then also we decided to deprecate this element, ERS 06. Folks felt like the following data element, this CARES data element, had more value. So who first initiated CPR, rather than asking who were all the people that provided CPR before EMS arrival, folks felt like it was really important to identify who was the first person to initiate CPR. And so CARES is on board with us for this data element. And so that's one area where we will have to make some changes, but we will be able to align here with CARES. So no change to this data element, that'll remain. We did decide to deprecate this data element who used the AED prior to EMS arrival. Kind of a similar thought process here to the CPR data element. Here, folks felt like it wasn't important to know who were all the people that used the AED prior to EMS arrival. It was important to know who had first applied the AED and who first defibrillated the patient. So those, you know, and those are CARES data elements with some slight changes to the field values. We'll be adding in that data element and who first defibrillated the patient. And I think, Clay, that might be it. Oh, so slight modification here. This is unrelated to the NEMSIS CARES harmonization, but folks felt like we needed some label changes and some additional field values for this data element. Oh, and then one more. You know, there was some discussion around this data element, but folks felt like this was important, even though you could document this in the e-procedures section. You know, folks felt like our goal of trying to make sure that, you know, we are capturing cardiac arrest data that's valid and reliable. There wasn't a good way for us to document a pertinent negative in the e-procedures section. So we're hopeful, I think, because this data element existed in a previous version 3, you know, that bringing it back wouldn't be too burdensome for folks. And that might be it, I think. The rest of it, no change.
Yeah, I think that is.
So those are the changes that you know, we'd like to see in the ERS section. You know, I think given that, you know, on CARES end, they were willing to make some changes on their end, plus do some mapping for 7 of those 14 that we were working through. You know, and initially, I think when the DMC was making those votes, you know, there was some thought that, oh man, we might have to make 12 changes to the ERS section. You know, we are making some changes here, but we're, you know, as in terms of the harmonization and the alignment, you know, we're not having to make changes to 12 elements. So, you know, I think we feel like this will reduce the burden of data entry. We're hopeful that it'll really work to decrease or hopefully, you know, eliminate some of those custom fields, and that providers will have an easier time, you know, documenting for their cardiac arrest patients. And if folks have questions, I'm happy to answer them. You know, of course, you can always email me or give me a call too.
Yeah, thank you, Jeremy. Anyone have comments about the revisions that Jeremy walked through? Jeremy, perhaps just one question for folks. Could you talk a little bit about who, in addition, you're hoping to familiarize with these revisions, and then perhaps if there might be a possibility of us releasing a document like this that would allow folks to speak to their stakeholders?
Yeah, so I know I'll make the same presentation to the data managers call that's coming up. We have it next week, right? I think CARES has been sharing this information on their end with their CARES. They're not data managers, but CARES, their state level folks. So yeah, you know, we're happy to share it with whoever. You know, I think this is a great venue to share it. But Clay, if you feel like there's other folks that need to be aware of these changes, we'd be happy to reach out to those folks.
Yeah, thanks, Jeremy. I think this presentation, this document that we walked through, this was prepared by NHTSA and I think by Jeremy specifically. I think it does a great job of walking folks through what it looks like now and what the potential changes will look like. I just might ask among the data managers or even among the vendors, do you feel like having a document like this would help you kind of familiarize your folks with these potential changes to NEMSIS and its ability to harmonize with CARES? Would a document like this help you as you kind of work through this process with your stakeholders, particularly those states that are CARES states?
This is Felicia Clay. Yes, it would help.
Yeah, great, Felicia. Any other comments in regards to maybe what in the way of materials could help you as states or vendors to make folks aware of these upcoming changes? Okay, well, I've kind of put Jeremy on the spot a little bit. This has been a working document that's been used by the CARES Harmonization Work Group, and so maybe we'll pull back a little bit, see if we want to make any other kind of revisions to this document, but this will probably be what will be distributed in the near future. So hopefully you as states can keep folks right on top of the changes that we're making. And of course, we're making these changes not in a vacuum. We have a great work group that's been incredibly helpful in helping us and understand how we could best bring the two standards together. But if you have CARES representatives in your state, it might be great to share with them, and if they see some nuance that we have missed that would be valuable, this would be a great way to kind of begin to familiarize folks with these changes who are practically on the front lines and see if there's some other small issue that maybe we haven't addressed. So that could be really valuable. Okay, great. Any other comments about the CARES NEMSIS harmonization? Okay, great. Thank you, Jeremy. That was helpful to walk through that document. All right, the last item we have on the agenda here is to provide you with some final decisions that were made in regards to elements in 3.4 that are national that could potentially be demoted to like a state level element, so thus not, quote, mandated or required to be in every run form. And the few that were that thought could be promoted to a national level and have real value. To review this, I'm going to try to take an approach similar to what Jeremy did and take folks back just a little bit in time and help you remember that in early 2017, as Jeremy mentioned, there was an open period of 6 months where folks were able to provide comments on potential revisions to the standard that would be valuable. Many revisions were suggested. We put together some work groups in the summer of 2017, and this was the work group that was associated with looking at many recommendations about the review of national elements. And I'm not going to go through this slide set, but I do want to just mention to you just the number of suggestions that were made. So you can just look here quickly. During that 6-month call, there was a request to promote 29 elements to national level and to remove, of the total of 29, there was 9 that folks thought may be able to move to the national level, 17 that should be demoted as national, and then some that potentially could just be removed because they're part of the state data set. So this was the initial work that was done by this group. We've reviewed this many times. I'll just quickly show the folks who did such a great job of going through all these elements and worked so hard to complete the work with this. this work group. There were 4 other work groups that put in equal amounts of hard work. Just wanted to show you the final decisions. So clearly work continued on this during all the way up to our meeting in Park City in 2018. And we have taken those revisions to NHTSA. They have reviewed them. Of course, you can imagine they have particular interest because these are national elements. And so the federal stakeholders, the professional organizations and others that they kind of answer to would be affected by an element that was demoted or promoted to national. So I'll just walk through these changes real quickly. People are probably familiar with most of these. We've been talking about them now for quite a long time, but it's been incredibly valuable to do that as a group of stakeholders within this industry. So you can look down here through column E. All of these were slated for removal. Those that are bolded here just indicates that these were actually mandatory elements that had to be completed. So as you take a look through these, many of these were in the D-agency section, kind of identifying an agency, their service area, population size, the volume that they of EMS activations that they handle. There were 2 elements that kind of talked about the configuration of an agency. So what type of specialty services did they offer? What monitoring capabilities did they have? And then some smattering of other elements in other sections of the NEMSIS standard. So in e-vitals, removing as a national element the method of blood pressure measurement, the element in the protocols that indicated whether this was an adult or pediatric category protocol. Then there were also changes to the e-medications procedures and disposition section 3 that the work group indicated could be demoted. NHTSA had an opportunity to review all of these suggested revisions and came back asking that we not make the changes to those 3 elements. That is response to medication, response to procedure, and then the capability that a hospital has in regards for time-sensitive issues. So trauma designation, STEMI designation, stroke designation. And then one additional element that was dropped and approved by NHTSA was the element indicating whether or not there had been a work-related exposure. This is a yes or no element and was at the national level. So I'll stop there just with these demotions or these that will actually be kept national. Jeremy, do you want to share a couple of thoughts about from the federal level why these were chosen to actually remain as national?
Sure, yeah, I'd be happy to. So again, as I mentioned when I was talking about the NEMSIS CARES harmonization, it's great to have these work groups and folks are really working hard. So we really, appreciate that. And it's clear that folks have been doing a lot of really great work. So, as Clay has kind of gone through this list, I mean, most of these, we agreed with because we certainly want to reduce the burden of data entry on providers as much as possible. And so, we agreed that for a lot of these, we didn't see value in keeping them at the national level. So we had some conversations with Clay, and he kind of kept us up to date on the work that the work group was doing and the results, and asked us for some feedback and what we thought. We really kind of here in the office thought about it in a number of different ways, but really we thought, is this data element valuable at the national level in terms of performance measurement, research, national level research, and evidence-based guideline development, or is it valuable in terms of syndromic surveillance at the national level? And so we had some discussions here in the office about each of those data elements and whether or not they allowed us to do any of those things that I just mentioned. And then we also reached out to folks across the country to get feedback from them. So we talked with folks at the EMS Performance Improvement Center, several, EMS researchers at other academic institutions. We talked with our federal partners at CDC and the HRSA EMS for Children program. Members of some of the national organizations like NEMSIS and the Pre-Hospital Guidelines Consortium. And while folks, regarding response to medication and response to procedure, I think while there was some varying opinions, folks did feel like, yes, they are subjective, as folks on the work group identified. But several folks told us that they are using them in combination with vital signs. So for instance, you have a patient who's suspected of opioid overdose. You can see that their vital signs do improve. Using that in combination with response to medication of improved adds some reliability. So we felt like it was important to keep that. And for similar reasoning, response to procedure, I mean, I think we understand it's subjective and that, there are situations where it doesn't make a whole lot of sense, right? So if you administer a 12 lead, response to procedure doesn't make a whole lot of sense. But as Clay and I were talking, we also realized that they're not mandatory. They do allow for a not applicable and a not recorded. So we really felt like it was important to kind of keep those two. And then hospital capability, is the only data element here at the national level where we can determine if a patient was transported to a trauma center or not. So that's one that's particularly valuable, I think, to us and our traffic safety partners and trauma organizations as well at the national level. So, and I don't know, Clay, if you want to talk a little bit about the hospital capability data element, how we might be able to improve how it's structured in some ways, and it's the schematron rules that are related to that data element, and how that might ease some of folks' concerns about e-disposition 23.
Right. Yeah. Good point. So, and as we've talked about with folks, and particularly among the states who are reviewing their NEMSIS data submission dashboard and looking at what errors are occurring across their agencies, they'll note that really this element, e-disposition 23, is most often the culprit of a national schematron warning. With the decision made by NETS, which makes really good sense, we've gone back to the drawing board, and actually Josh is coming out to meet with us this week, where we're going to hone down very specifically to determine if we can develop some schematron rules, even though most of the schematron rules we try very hard not to have the rules be used to guide data entry, but to just indicate whether a response is valid. This may be a situation where we may be able to use schematron to some extent to limit when it is required to be present, right? So clearly, if you're just transporting a child who is sniffly or feverish, there really isn't a strong reason to ensure there's a schematron warning to ensure that hospital capability is reported here. So we're going to work with Josh to see if we can improve the schematron rules in a way that will really reduce the number of warnings that your providers are seeing as they're completing a record. So any questions for Jeremy regarding these elements that will be demoted or kept at the national level? Okay, as always, feel free if you think of a comment. I know Jeremy's incredibly open to receiving email from you folks, and of course either Lisa, Monet, or I here in the TAC I would love to hear from you if you have some comments. All right, and then you'll just notice there are 4 elements that I kind of set aside that are also being were considered for demotion. Actually, these elements will be removed from the NEMSIS standard. These are all variables that sit within the demographic dataset standard, e-configuration 02 through 05. These are elements that are essentially found in the state dataset. And as folks may remember, for version 3.5.0, the state dataset will become required in regards to compliance testing for products, for state level products, and then also receiving that state dataset here at the TAC. It serves an incredibly important mission. And if folks want to revisit that, I'd be happy to talk to them after the call about the value of the state data set. But the fact that these elements are now part of that state data set, so moving forward in version 3.5, there'll basically be three standards. There'll be the event data set that we're familiar with, the demographic data set, and then the state data set. These all being in the state data set, they will be removed from the demographic standard. So all in all, I think here we'll see there are eight, I think 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16 elements that will be demoted from national or removed from the standard. So any questions about demotions or removals? Okay, great. We can walk through the promotions, the elements that were not national, that is not mandatory or required, that folks felt like could be promoted and have great value. There were basically three that came out of the work group in 2017 and were approved as we reviewed them again through 2018, and particularly in Park City. There were three that kind of made it through most of that discussion. And you'll note here that really once we had good discussions with many stakeholders, including NHTSA, Jeremy talked about the work that they did there. There's only two that will be promoted: e-situation 18, date and time of last known well, and also e-medications 04, the medication administered route. The other element that was went through the process fairly far was E-02, dispatch notified date and time. But through the voting and through our conversations with NHTSA, that was decided not to promote that element. I'll just mention here again, promoting last known well will have great value for many of the registries that rely on NEMSIS data. So STEMI, stroke, cardiac arrest registries, knowing that the time the patient was last known well is incredibly valuable. But clearly, again, it's an element that even if it's just required, which it will be, so you can use null values. Clearly, there's situations where this variable will be less important. So again, as we develop schematron rules to help the performance of data collection, we'll work to ensure that those are carefully worded, and so warnings only appear when there is a time-sensitive issue at hand. So, any questions in regards to the promotions? Okay, great. All right. All right, that was the last of the formal agenda that we had prepared for the meeting today. As we start a new year, and folks, we appreciate your willingness to be with us on this journey as we complete the V3.5 process and actually complete the V3 movement across the country. Any other items that you'd like to discuss or like further clarification on, either related to what we talked about today or future items that you'd make sure that we talk about early in this year? All right, a really quiet group today. Maybe people are still recovering from the idea that they're starting a new year. We very much appreciate your your participation today. Thank you. It's incredibly valuable that we have such a great group of folks that are dedicated enough to get on this call with us twice a month and make sure that we all stay up to date in regards to what's happening with NEMSIS. Thank you for your commitment to that. And then again, if you have questions, if you have issues that you'd like to cover with anybody here at the TAC, please feel like you can go to our website. Under support, all of our contact information is made available, so please feel free to contact us. And then I'm sure that Jeremy Kinsman at the national level at NHTSA, he has been incredibly involved in the work of V3, and so would be happy to take your questions as well. Other than that, thank you very much for joining us. Have a great week, and we'll talk to you in a couple of weeks. Thank you.
Thanks.
Thank you.
By the way, Clay, I think the Zoom works quite well.
Oh, great. Thank you, Chuck. Yeah, we've had a couple other comments like that. Yeah, we're hoping that this will be a little bit more robust and reliable. Yeah, so thanks, Chuck. This should work better.
Yeah, and I've used it in a couple other applications too that work quite well too.
Oh, good. Okay.
Okay.
All right. Thanks, Chuck.
Mm-hmm.
Okay.
Bye.
Bye-bye.